Okay, let us again look some abnormalities of liquor and or amniotic fluid disorders. Let us look as an introduction. What is the physiology of amniotic fluid? In early pregnancy, amniotic fluid is secreted by the amnion, and this amnion is the part covering the placenta and the umbilical cord. So this fluid is also exudated from maternal vessels in the placenta. So when pregnancy continues to the second trimester, from the 10th week of gestation, the fetus begins to urinate, swallow, and inspire this fluid. And during the last 2/3 of pregnancy, amniotic fluid is principally consisting of fetal urine. So amniotic fluid increases in amount throughout pregnancy, just from a few millimeters until about 38 weeks, when it makes about 1 liter. And after 30 weeks of gestation, the amniotic fluid starts to go down, to diminish to about 800 mils at term. It is exchanged as often as 3 hours. So every 3 hours, amniotic fluid is refreshed by the placental cells. And when we say amniotic fluid disorders, what are these? One, we have which we call polyhydromnious. Polyhydromnious is a condition where there is excessive amniotic fluid in the uteri, which exceeds 1,500 mils. We've said it progresses from about what? I'm forgetting. We have said it progresses from just a few milliliters to about a liter. A liter is 1,000 mils. So if it is above 1,000, it is coming to 1,500 mils. Then this is already a polyhydromnious. Or we can say this is when the calculated amniotic fluid index pocket in the 4 quadrants is greater than 24 centimeters. This can be seen on ultrascan, and this can be a report from ultrasound scan. But for us, we can take it as simple as any amniotic fluid greater than 1,500 mils. So we have the types of amniotic fluid of polyhydromnious. One is acute polyhydromnious. And 2, we have chronic and acute. So for the chronic polyhydromnious, it has a gradual onset, usually from about 30 weeks of pregnancy. So it will develop slowly from about 30 weeks of pregnancy, maybe when the pregnancy is near to term. But in early pregnancy, the mother will be fine. So when we say acute polyhydromnious, this occurs very early, at around 20 weeks. It appears very suddenly. From the blue, the uterus suddenly reaches the cervicsternum in about 3 to 4 days, and it is often associated with monozygotic twins or severe fetal abnormalities. So for the acute, it occurs very early, that is in about 20 weeks, that is the second trimester. So from the blue, the mother will report an expanded abdomen, and it will be palpated at around the cervicsternum. And the mother will report the occurrence to have occurred within 3 to 4 days. And when this is got, the suspected first cause may be monozygotic twins or severe fetal abnormalities. So when we talk of the cause is unknown, but there might be associated factors. So when we look at the maternal side, diabetes mellitus, which causes fetal hyperglycemia and resulting into polyuria. We have said that at around term, the amniotic fluid is basically fetal urine. So if this baby mother is diabetic, it means that even the fetus will get hyperglycemia and also have signs of polyuria. Severe preeclampsia, congestive cardiac diseases, multiple pregnancy, especially in monozygotic twins. Here they say that identical twins may cause polyhydramnios, especially if one twin gets too much blood flow and the other too little. Rhesus incompatibility between the fetus and the mother can also predispose to polyhydramnios. So when we talk of fetal causes, multiple fetus is one of the two, and into these multiple fetus, usually what we call a twin-to-twin transfusion syndrome, which I think was looked at during multiple pregnancy. Then fetal congenital abnormalities, especially of the CNS, like the spina bifida, the myelomeningocele, etc. Then the gastrointestinal congenital abnormalities, right from the mouth to the anus, that is esophageal atresia, duodenal atresia, etc. Then we are continuing with fetal congenital abnormalities, fetal renal disorders, which may result into increased urine production, cleft lip and palate. So all this is associated with fetal abnormalities. So signs and symptoms. On general examination, 1, there is edema of the lower limbs, the ankle, and the vulva. On abdominal examination, on inspection, the uterus is larger, and at term, the girth is more than 100 centimeters. The girth is measured across with a tape measure. But this mother, on just a look, the abdomen will be very big as compared to the weeks of amenorrhea. The shape of the uterus is globular other than ovoid. Remember, the normal shape of a pregnant abdomen should be ovoid. This time, it may look globular on just looking. The abdominal skin is shining with prominent veins. That is self-explanatory due to overstretching. Then on palpation, the uterus will feel tense, and it is difficult to palpate and feel for the fetal parts as they are floating away from the examination finger. Remember, during abdominal palpation, on lateral palpation, you steady one side, and then on palpation, you can feel a continuous curve, and then on the other side, you can feel the nodules, which may give you a probable position of the fetus. But this time, when you try to palpate, it is very difficult to palpate for the fetal parts. And the uterus feels so tense, it is so full that you cannot palpate. So, a fluid throughout may be felt. Like as you try to ballot, you can feel a gush of water being palpated. There may be even an unstable lie. Like as you try to palpate the first time, you feel the head is down. As you try to find it more clearly, you can find the head moving in the transverse direction. So we have what we call an unstable lie. On auscultation, the fetal heart is very difficult to hear. Why? Because we are failing to get the position of the fetus, and we cannot place a fetoscope. This baby is also having an unstable eye, so we cannot locate the side where to listen the fetal heart. So it may be hard for us to listen to the fetal heart. So on investigations, so if you have all that difficult during abdominal examination, you send this mother for an ultrasound scan, which will diagnose polyhydromnious. So on that, we shall continue to screen the mother for diabetes, for ABO rhesus incompatibility, because they may be the risk factors for polyhydromnious. So management. This is not managed in a maternity center, therefore a mother should be referred to hospital. So this means that as a midwife, you should be in position to make a clear diagnosis and refer this mother early to hospital. So during management, you take history, and on history here, the key things you ask about is the last normal menstrual period, and on that you shall calculate the weeks of amenorrhea. So after calculating the weeks of amenorrhea, you shall know the expected fundal height. You do the observations as usual. You do the general examination from head to toe to rule out edema and anemia, and more preferably, this mother will be having a degree of edema. Then abdominal examination is carried out to estimate the level of fundal height, presentation, position, and fetus. And remember, we said that abdominal examination is very difficult. The abdomen will be tense. The fundal height will be greater than the weeks of amenorrhea. The presentation may be very hard to get. Even the fetal heart may be hard to get. So after that, you write a referral note and refer this patient to hospital. So when the patient reaches hospital, in mild cases, the mother may be managed at antenatal clinic at frequent intervals as ordered by the doctors. And in severe cases, this mother should be admitted. And during the admission, our aim is to find optimum care for the condition of the mother and, of course, the fetus. And the first thing, this patient will be put on bed rest, preferably in an upright position. This upright position will relieve the heartburn and dyspnea. Why does this patient has dyspnea? The uterus is pressing on the diaphragm, and the diaphragm is pushing on the lungs. Therefore, the lungs are having limited capacity, which may lead the patient to have problems with breathing, which can be evidenced by tachypnea. We reassure the patient. Of course, we have to tell her what is happening, what is the prognosis. Yes, we may repeat to take histories, to take the observations, the blood pressure and the fetal heart. We continue to do the general examination and the abdominal examination. We can also prepare a tray for investigations. So for investigation, we can also not omit to rule out the hemoglobin level, the malarias, the grouping and cross-matching. If this mother looks anemic, we send this mother for ultrasound scan. Here we would specifically want to find out the state of liquor and what is the degree of polyhydromnious. Then this mother may be given sedatives such as Valium or phenobarbital to ensure rest, because of course anxiety must set in. So if this mother goes into labor, first stage of labor, we shall properly monitor the mother by use of a partogram, as she may be on oxytocin drip after rupture of membranes. So due to excessive stretching of the uterus, this mother may either start early contractions, or the doctor may be coerced to rupture the membrane and let them leak very slowly, because we don't need to rupture them abruptly. We may lead to cord prolapse. And if these membranes have been given way, this mother can be put on induction. So during an induction phase, we monitor this mother closely. We monitor the fetal condition, the maternal condition, plus the progress of labor. If there is no indication, if there is no contraindication to vaginal delivery. We have said artificial rupture of membranes may be indicated because it may aid descent, engagement and descent. But to take note, rapid rupture of membranes may also lead to cord prolapse. So any abnormal progress in first stage should be reported, that is as per partograph. Strict monitoring of fluid output and input by use of fluid balance chart is very key, and the mother should be rehydrated orally by being given tea. So we monitor the first stage as any usual stage, but keeping a keen eye on the progress. So second stage, we said this baby is very prone to abnormal lies. So after the membranes have been released, and after this mother has been fully dilated, we can reassess the fetal lie and position, and even the nature of the maternal pelvis in relation to the fetus. If these membranes rupture and this baby is transverse, then we cannot proceed with second stage. But if this baby helps us and engages and is in a longitudinal lie with a very normal pelvis, we shall continue to conduct second stage. So third stage is also managed by controlled cord traction under oxytocin drip to prevent postpartum hemorrhage. So care of the newborn, immediate care of the newborn is as any other baby, but this time, remember, polyhydramnios is associated with a lot of congenital abnormalities. So during newborn examination, we should be ready to rule out congenital abnormalities. A key congenital abnormality we talked about is an esophageal atresia, heteroesophageal atresia, which can be confirmed by passing an NG tube. And if the NG tube is not progressing, it means we may have a tetraesophageal atresia. So this baby can be taken to nursery for its management. So if the mother is having polyhydramnios, what are the effects? This mother will present with pressure symptoms, heartburn, breathlessness due to a big fundus, indigestion, vomiting, varicose veins, abdominal discomfort, and this mother is prone to antepartum hemorrhage due to placental abruption, then abortion due to acute polyhydramnios. Then to the fetus, as we have looked above, the fetus can be of an unstable lie and it is prone to congenital abnormalities. So effects on labor is collapse of the mother if liquor is released very suddenly. That is why I said that rupture of membranes should be done cautiously to prevent maternal collapse and also to prevent fetal prolapse. Then, due to overextension of the uterus, it can lead to premature labor. Prolonged labor may be due to hypotonic uterine contractions. Malpresentation, that is very obvious. Early rupture of membranes, abruptio placenta, PPH due to very relaxed muscles. These all may occur. So how about in postpartum? We can have secondary postpartum hemorrhage, subinvolution of the uterus. This can be due to overstretching of the uterus. Infection and puerperal sepsis are key. Puerperal pyrexia due to retained products and infections. Yes, and our fetus is very prone to prematurity, fetal hypoxia, and malpositions as discussed before. So with these few remarks, I think polyhydramnios, we have gotten a little tip.